Right. I'll just give a few seconds for everyone to join in.
Sure, sir.
Okay, how many people have joined?
So 11 are waiting, sir.
Okay.
You can start the session. Meanwhile, they can join on the link.
Right. Okay, we'll get started. So, a very good morning to all the students. We'll be covering the topic of diseases of the penis and urethra today. It's a very big topic. There are lots of conditions that I want to touch upon. So, we'll not go into much detail of each one and we'll try to cover as many topics as possible. There's a lot to cover. I'll be a little fast today. And most of you should be aware of the surgical anatomy. It's very relevant even at the undergraduate level. So the penis is composed of three cylindrical structures, the paired corpora cavernosa and the corpus spongiosum, which houses the urethra. This is covered by the Buck's fascia, then the Dartos fascia, and the skin. Embryologically, the glans penis is derived from the genital tubercle, the penile shaft from the urogenital folds, and the labioscrotal swellings give rise to the scrotum. Corpora cavernosa are two spongy paired cylinders. They are contained inside a thick envelope of tunica albuginea. It forms the major portion of the body of the penis as they join beneath the pubis. They are attached to the inferior ischiopubic rami and perineal membrane and are surrounded by ischiocavernosus muscles. There's a septum that separates the two cylinders, and it's permeable for free communication between the vascular spaces. A conglomeration of sinusoids, larger in center and smaller in periphery. In the flaccid state, blood slowly diffuses from the central to the peripheral sinusoids, and blood gas levels are similar to those of the venous blood. During erection, there's a rapid entry of arterial blood to both the central and peripheral sinusoids, which changes the intracavernous blood gas levels to those of arterial blood. The corpus spongiosum, it dilates as bulb of the penis and is fixed to the center of the perineal membrane. It is encompassed by the bulbospongiosus muscle that arises from the perineal body and from a central tendinous raphe, and it passes around the bulb to attach to perineal membrane and dorsum of the penis. The glans penis is the distal expansion of corpus spongiosum. Structure of the corpus spongiosum and glans are similar to corpora cavernosa, except the sinusoids are larger and they contain less erectile tissue, and the tunica is thinner in the spongiosum. There's only a circular layer. So tunica albuginea consists of fibrillar collagen, mostly type 1 and some type 3, and elastin. This allows tunical expansion and helps to determine the stretched penile length. It's a bilayered structure, inner layer circular, outer layer longitudinal. The inner layer supports and contains cavernous tissue, and there are intracavernous pillars that act as struts to augment the septum, and they also provide support to erectile tissue. The outer layer, longitudinal one, extends from the glans to the proximal crura. It inserts into the inferior pubic rami. It is only absent at the 5 and 7 o'clock position. Most of the prostheses tend to extrude from this place. So this is a applied surgical concept that there's a weakening at the 5 and 7 o'clock position. So if a prosthesis is placed inside the corpora cavernosa, it may extrude from the 5 o'clock or 7 o'clock position. It affords great flexibility, rigidity, and tissue strength to the penis. And with erection, the outer longitudinal layers and inner circular fibers tightly become stretched. In the flaccid state, they form an undulating meshwork. In contrast, corpus spongiosum lacks an outer layer or intracorporeal struts, ensuring a low pressure structure during erection. There are emissary veins which run between the inner and outer layers of the tunica. The outer tunical layer has a role in compression of emissary veins during erection. The Buck's fascia. This is one of the most important layers of the penis. It's a tough elastic layer. It is immediately adjacent to tunica albuginea. It surrounds the corpora cavernosa dorsally, and it splits to surround the spongiosum ventrally. It contains the deep dorsal vein, the paired dorsal arteries, and multiple branches of dorsal nerves on the superior aspect of corpora cavernosa. So this is the layer where you will find all the important neurovascular structures. Attached distally to undersurface of glans penis at corona, the Buck's fascia extends into the perineum. It encloses each crus and the bulb of corpus spongiosum. This helps for firm fixation to the pubis, ischium, and inferior fascia of perineal membrane. Distally, the skin of the penis is confluent with the glabrous skin covering the glans, and at the corona, it is folded on itself to form the prepuce. The dartos fascia, it's a layer of areolar tissue remarkable for its lack of fat. This is a typical finding in the scrotum and in the penis, that there is no subcutaneous fat, in contrast to other layers of the abdomen, because all of these are derived from the abdominal layers. Continues into the perineum, where it fuses with the layers of the superficial perineal fascia. In the penis, the dartos fascia is loosely attached to the skin and the deeper layer of Buck's fascia, and this allows free movement of the penile skin. This layer contains the superficial arteries, veins, and nerves of the penis. The penile shaft skin, so it is very elastic and mobile because of the loose dartos fascia backing. There's smegma production from the glands that are located in the prepuce, preputial glands of Tyson. They are located at the base of the corona. In uncircumcised men, the prepuce is the penile skin, which folds over the glans and attaches below the corona. And the glans penis skin is immobile. It is attached firmly to the tunica albuginea below it. Ligaments of the penis. So there's a fundiform ligament, as you can see, this one, like a hammock. It arises from the Colles fascia and is lateral, superficial, and not adherent to the tunica albuginea of the corpora cavernosa. It is continuous with the lower end of the linea alba. So this is the linea alba, the midline structure in the abdominal wall, and it is connected to the linea alba, the fundiform ligament. And it splits into laminae that surround the body of the penis and unite beneath it. So it's like a hammock. It is not important to preserve this structure at surgery. Suspensory ligaments. So these arise from the Buck's fascia. They're attached to the anterior aspect of the symphysis pubis. These are the suspensory ligaments. These are very important. These are much stronger than the fundiform ligament. They consist of two lateral bundles and one median bundle. Function is to attach the tunica albuginea of corpora cavernosa to the pubis and provide support for the mobile portion of the penis. In patients with congenital deficiency, or this ligament has been severed in penile elongation surgery, erection may be unstable or the penis may droop, because this is an essential component of support to the penis during erection. So this is a cross-sectional diagram. In the middle, you can see the two corpora cavernosa. This is the corpus spongiosum. There's a layer of tunica albuginea, which has an outer longitudinal and an inner circular layer. The internal part of the corpora cavernosa is composed of erectile tissue. The cavernosal artery runs through the middle of this tissue, and there's a little subtunical space below the tunica albuginea. Above that is the layer of the Buck's fascia, this layer which has been reflected upon here, and it contains all the important structures, the dorsal arteries and dorsal vein. The superficial dorsal vein is outside the Buck's fascia. The deep dorsal vein is within the Buck's fascia. Okay, above that is the dartos fascia. So the two fascia, the deeper one is the Buck's fascia, and the outer one is the dartos fascia. The dartos fascia contains the superficial dorsal vein. And after that is the skin, which is a loose structure. Okay, these are the columns or pillars, the intracavernous pillars, which provide support to the septum as well as to the erectile tissue. All right, so each component has some function, like the corpora cavernosa, which supports the corpus spongiosum and glans. The tunica albuginea contains and protects the erectile tissue, and it also provides rigidity to the cavernosa. It also participates in the veno-occlusive mechanism, as we talked about earlier. The emissary veins get compressed between the outer and inner layer of the tunica albuginea, so the blood flow away from the penis is blocked. This helps to maintain the erection. Smooth muscle. It regulates blood flow in and out of the sinusoids. Ischiocavernosus muscle. It pumps blood distally to hasten erection. It provides additional rigidity during rigid erection phase. The bulbocavernosus muscle, very important for the expulsion of semen, the ejaculation part. Corpus spongiosum, it pressurizes and constricts the urethral lumen to allow forceful expulsion of the semen. And the glans, which acts as a cushion to lessen the impact of the penis on the female organs. It provides sensory input. It is very rich in nerve supply. And it facilitates intromission because of its conical shape. Okay. Arterial supply. So there's a superficial arterial system and a deep system. The superficial system originates from the external pudendal arteries. The skin of the penis, supplied by left and right superficial external pudendal vessels. They run longitudinally in the dartos fascial layer, as we saw earlier, and they arise from the first portion of the femoral artery. They form a rich subdermal vascular plexus. They can sustain the skin after its underlying dartos has been mobilized. So they have their own vascular supply. The skin and dartos has their own blood supply. This is the reason why we are able to use uh, various kinds of dartos grafts in different reconstructive surgeries. Because of its remarkable thinness and mobility and character of its vascular supply, the skin covering the penis is an ideal substitute for urethral reconstruction. That's what. Blood supply to the scrotal wall and ventral penile skin is from the posterior scrotal artery. A deep arterial system arises on each side from the internal pudendal artery, and which is a branch of internal iliac artery. The internal pudendal artery becomes the common penile artery after giving off a branch to the perineum. It travels along the medial margin of the inferior pubic ramus, divides into three major branches: the bulbourethral, the dorsal artery, and the cavernous artery. Distally, they join to form a vascular ring near the glans. The bulbourethral artery, it pierces the buccal fascia to enter the bulbospongiosus muscle. It is oriented parallel to the path of the membranous urethra. It provides arterial supply to corpus spongiosum, the glans, and the urethra. The cavernosal artery, it affects tumescence of corpus cavernosum and enters at the hilum of the penis where the two crura merge. It gives off many helicine arteries, so they run perpendicular and they supply the trabecular erectile tissue and sinusoids. They are contracted and tortuous in the flaccid state and dilated and straight in the erection phase. The third is the dorsal artery of the penis. It travels along the dorsum of the penis between the deep dorsal vein medially and dorsal nerves laterally. So I'll go back to that diagram again. This one, yes. So this is the location of the dorsal artery, the two red circles. It lies between the dorsal nerves and the dorsal vein. So the artery is between the vein and the nerves. So here also you can notice it's vein, artery, nerve, medial to lateral. All right. It gives off 3 to 10 circumflex branches, the circumflex cavernosal arteries. They provide vascularity to the corpus spongiosum, and they're responsible for engorgement of the glands during erection. Variation, sometimes a single cavernosal artery may supply both cavernosa. It may be absent as well. An accessory pudendal artery may be the source, or it may supplement branches of common penile artery. There are sometimes accessory arteries arising from external iliac, obturator, and vesical and femoral arteries. There have been different classifications for the abnormal penile arterial supply. I don't think we need to go into this. All right, so we've talked about the supply from the superficial external pudendal artery and vein. These are the superficial ones, and this is the deep one, the internal pudendal artery, the deep penile artery, the perineal artery. After giving off the perineal artery, and obviously there is posterior scrotal artery as well to the scrotum. This is a better depiction of the main arterial supply. So this is the common penile artery. So the internal pudendal gives away a perineal branch and becomes the common penile artery. The common penile artery gives off a bulbourethral branch or a bulbar artery, which supplies the bulb. Then there is a dorsal artery of the penis, which is the main artery, on one on each side, and there are also internally, this one going inside, it pierces the buccal fascia, goes inside the tissue of the corpus cavernosum, which is known as the cavernosal artery. The circumflex arteries are branches from the dorsal artery. So this one is the dorsal artery. It gives off circumflex artery branches. Internally, there is the cavernosal artery, which gives off helicine branches. And the first one was the bulbar artery. So this is the main thing that you need to remember in the arterial supply of the penis. Venous drainage. So all the three corpora, the two cavernosa and one spongiosum, the venous drainage originates in tiny venules from the sinusoids. They form subtunical venous plexuses and then exit as emissary veins. The penis is drained by three venous systems, the superficial, intermediate, and deep. Superficial veins are contained in the dartos fascia, as we saw, and then they unite to form a single superficial dorsal vein draining into the left saphenous vein. This is something that you saw in the dartos layer. The intermediate system contains the deep dorsal and circumflex veins. They are beneath the buccal fascia. The emissary veins begin with within the erectile space of the cavernosa, and then they empty into the circumflex veins. The circumflex veins prominently present in the distal two-thirds of the penile shaft. They arise from the spongiosum. They receive the emissary veins and they empty into the deep dorsal vein. The deep dorsal vein is formed by 5 to 8 small veins, and then they gather blood from the emissary and circumflex veins and leave the shaft of the penis at the crus and drain into the periprostatic plexus. The superficial dorsal vein lies external to the buccal fascia, whereas the deep dorsal vein is beneath the buccal fascia. So this is a take-home point you should remember. Deep drainage system consists of the crural and cavernosal veins. The crural veins arise in the space between the crura. Emissary veins form 1 to 2 cavernosal veins on each side and drain into the internal pudendal vein. The internal pudendal veins are 2 in number, empty into the internal iliac vein. They communicate freely with the dorsal vein complex by piercing the levator ani, and these communicating vessels can be a source of bleeding during the apical dissection of the prostate. So during radical prostatectomy, although we ligate the dorsal venous complex, there can be some bleeding from these communicating vessels. Okay, so basic concept, this is the deep dorsal vein. It is very much like the deep dorsal artery of the penis. There are circumflex veins draining into it, just like the circumflex artery branches of the dorsal artery. And then there's one bulbourethral vein, just like the bulbourethral artery. All of this, okay, this goes and communicates with the periprostatic plexus located here. And the internal supply also goes finally into the internal pudendal vein. There's this cavernous vein, just like the cavernous artery as well. So there's a plexus here as well, around the glans. Retrocoronal venous plexus. Okay, so more or less, I think we have a good idea of the arteries and veins and nerves of the penis. Right, nerve supply, the pudendal nerves and the cavernosal nerves. Pudendal nerves arise from S2, S3, S4, supply somatic, motor, and sensory innervation to the penis. Pudendal nerve passes through the Alcock's canal and continues as the dorsal nerve of the penis. A lot of MCQs originate from these parts of the surgical anatomy of the penis. Cavernosal nerves, combination of parasympathetic and visceral afferent fibers, and constitute the autonomic nerves of the penis. This is a part of the erectile apparatus, and this gets damaged during radical prostatectomy. So erectile dysfunction is a common complication of radical prostatectomy. The dorsal nerves, sensory innervation of the penis, they are richly located in the glans, and small branches of perineal nerve, they supply the ventrum of the penis as distally as the glans. Right. Somatic pathways, I think we can go ahead. Lymphatic supply, so superficial and deep lymphatic system. The superficial drains the prepuce and the skin of the shaft. It converges dorsally and then divides at the base of the penis. And it drains into the right and left superficial inguinal nodes. So this is very important. Malignancy involving the prepuce will usually lead to the enlargement of superficial inguinal lymph nodes. The deep lymphatic system drains the glans penis towards the frenulum. Large trunks are formed and encircle the corona to unite with those from the other side on dorsum. They traverse the penis to the base within buccal fascia. They drain through pre-symphyseal lymphatics into superficial nodes and then to deep nodes as well. Penile cancer can metastasize to contralateral inguinal lymph nodes as well because of crossover in the symphyseal region. So this is very important. That is the reason why during the management of inguinal lymph nodes, we have to take care of both the sides. So we do at least a biopsy or a sampling on both the sides if there is a risk of inguinal mets. The inguinal lymph nodes then drain into the same-sided pelvic lymph nodes. So the inguinal lymph nodes are divided into superficial and deep groups based on their location in comparison to the deep fascia of the thigh. The deep fascia of the thigh is known as the fascia lata. So those which are above the fascia lata are called the superficial group, and those which are deep are known as the deep group. The superficial group consists of 4 to 25 lymph nodes. MCQ point again. They're situated in deep membranous layer of the superficial fascia of the thigh. They're divided into 5 anatomic groups. Remember, 1, central, around the saphenofemoral junction. 2, superolateral, around the superficial circumflex vein. 3, inferolateral, around the lateral femoral cutaneous and superficial circumflex veins. 4, superomedial, around the superficial external pudendal and superficial epigastric veins. I'll come to the anatomy of the saphenofemoral junction later in my class today. Inferomedial nodes around the great saphenous vein. So central, superolateral, inferolateral, superomedial, inferomedial. It's very easy. You put a central point and then put 4 points around it. Superolateral, inferolateral, superomedial, inferomedial. So these are the 5 anatomic groups of lymph nodes in the inguinal region. The deep inguinal lymph nodes are much fewer in number. They may be 3 or 4 in number. They lie primarily medial to the femoral vein in the femoral canal. Point to be noted is there's a node called the node of Cloquet. This is the most cephalad deep inguinal lymph node. It is situated between the femoral vein and lacunar ligament. So when we're doing a deep inguinal lymph node dissection, we must reach up to the Cloquet's lymph node. Deep inguinal obturator and hypogastric group of lymph nodes drain into the external iliac lymph nodes, which drain into the common iliac and para-aortic lymph nodes. So this is a very useful diagram and picture. This is the femoral vein. This is the great saphenous vein draining into the femoral vein. So this is the saphenofemoral junction. So this is the superficial epigastric vein. This is the superficial external pudendal. So superomedially is the superficial external pudendal and superficial epigastric. Inferomedial is the medial circumflex. Inferolateral is the lateral circumflex, and superolateral is the superficial circumflex iliac vein. So these are the 5 major tributaries of the saphenous vein at the SF junction. And this is the lymph node of Cloquet, the superior most medially located to the femoral vein. This is the limit of our dissection when we are doing a deep inguinal lymph node dissection. All right, this is the zone that you classically would need to dissect. The limits of standard and modified groin dissection. So originally, the standard groin dissection, you have to dissect up to here. You should note that this is the sartorius muscle. This is the inguinal ligament, and medially there is adductor longus. So we dissect in this zone. Shorter modified groin dissection is performed now with comparable or equal results and less complications. Okay, let's go to the topic of carcinoma penis now. We've dealt with the surgical anatomy of the penis. One of the biggest topics today to discuss is carcinoma of the penis. So the staging, carcinoma in situ. This staging keeps changing a little bit with every passing year. So I don't think they'll ask you in detail about the cancer staging, but the basic idea is TA is a non-invasive verrucous carcinoma. 1A invades the subepithelial connective tissue without lymphovascular invasion, and 1B invades subepithelial connective tissue. 2 is corpus spongiosum or cavernosum. 3 invades the urethra. 4 other adjacent structures. Okay, lymph nodes. N1, palpable, mobile, unilateral. N2, palpable, mobile, multiple or bilateral. N3, palpable, fixed or a pelvic lymphadenopathy on imaging. Distal mets, M1. Okay. Broder's classification, this is for the histologic grading of the squamous cell carcinoma. You should remember the name. They won't ask you the details of the grades. Okay, treatment of the primary. So if first of all, a biopsy is mandatory to establish the diagnosis of carcinoma of the penis when there's a suspicious lesion. On biopsy, if there's a carcinoma in situ, some topical treatments like the application of 5-fluorouracil or 5% imiquimod, or a topical laser therapy may be sufficient for treatment. If there's varicose carcinoma, excision is the first choice. Mohs micrographic surgery, I'll talk briefly about it later. This is another option. T1A involving the foreskin, the treatment is a wide circumcision, and that is enough. For T1A involving the glans penis, an excision or glansectomy is the treatment of choice. An alternative is the use of Nd:YAG laser. T1B involving the foreskin, again, a wide circumcision may be enough. And for glans penis, a wide local excision with skin grafting or a laser excision or a complete glansectomy may be the treatment of choice. For T2 involving the glans, a complete total glansectomy is done. And for T2 involving the shaft, a partial penectomy needs to be done. T3 onwards, total penectomy with a spatulated perineal urethrostomy is the treatment of choice. In T4 disease, neoadjuvant chemotherapy is given first. If there is a good response, we may need to do a total penectomy. If there's no response, we continue with chemo or radio. Treatment of the penile lesion, so organ preservation and penile amputations. The goal is to preserve gland sensation wherever possible to maximize the penile shaft length. Indications are primary tumors which have favorable histologic features and the early stages like the T in situ, TA, T1, and only low grade or grade 2 tumors. So circumcision and limited excision strategies. Previously, 2 centimeter surgical margin was advocated for all the wide local excisions or partial penectomies. But now a 5 millimeter tumor-free margin or surgical margin for all grade 1 tumors and grade 2 tumors, and 10 millimeters for grade 3 tumors is recommended. So we can leave maximum length stump of the penis by just keeping a surgical margin of only 5 millimeters if the biopsy is grade 1 or grade 2 tumor, and 10 millimeters if it's a grade 3 tumor. The limitations are obviously proximal and distal deeply invasive tumors. You cannot do this. And high grade tumors, you cannot have a small margin. In skip lesions, it may cause recurrence. And the recurrence rate is quite low after surgical excision. It's only 4 to 6%. So this is a lesion on the glans. This is how the skin is mobilized, and this is how, with the skin, only this much wide local excision of the glans can be done, and then a reconstruction can be performed in this way with the preputial flap. This is a finely meshed split skin graft which has been quilted on the glans defect. Okay, Mohs micrographic surgery, just a couple of lines about it. So it involves layer by layer complete excision of the penile lesion in multiple sessions, fixed tissue technique, and a microscopic examination is done of each surface until the lesion is completely excised. The local recurrence rate is 8 to 32%, and with higher tumor size and advancing stage, it would not work. So it is basically suited for the carcinoma in situ or small superficial invasive tumors with cure rates comparable to partial penectomy. By this method, you can preserve maximum length of the penis while ensuring tumor-free status. Complications are meatal stenosis and glans disfigurement. Laser ablation, so circumcision is generally recommended at the time of laser therapy if it has not been done already. The 4 most widely used energy sources are the CO2 laser. It has a skin depth of 0.01 mm. It is optimal for carcinoma in situ. Nd:YAG laser, which is the most commonly used in penile lesions. It has a depth of penetration of 3 to 6 millimeters, so much more than a CO2 laser. And it is used for treating small superficial penile lesions. The KTP lasers, they are intermediate depth of penetration. They have better hemostasis than the CO2 laser. Disadvantages, tissue is not available for assessment, and there is a difficulty in determining the exact depth of the laser coagulation, and you cannot treat larger lesions with laser. And it is potentially difficult healing in patients who are obese, immunocompromised, or receiving anticoagulation therapy. Contemporary penile amputation. So partial or total penectomy should be considered in patients with tumors of size 4 centimeter or more, a grade 3 lesion, or lesions invading deeply into the gland's urethra or corpora cavernosa. So, deep invasion, grade 3 lesion, or a big tumor are indications for a partial or total penectomy. It remains the most common surgical procedure, the partial penectomy, for treatment of primary tumor, and successful control is accomplished in majority of patients. At least 2 centimeter proximal to the tumor. This is an old dictum, and as I said earlier, now we accept surgical margin of only 5 millimeters for low grade and 10 millimeters for high grade tumors. The additional goals of the procedure are to preserve the ability to void in a standing position and possibly allow sexual function. The local recurrence rates after partial or total penectomy range from 0 to 8%. Complications: urethral meatal stenosis, inability to void in upright position, spraying or splaying of the urinary stream, and inadequate sexual function. So this is basically, you put a glove or uh, anything to just isolate the tumor away from the surgical field. You place an incision proximal to the tumor, and then with superficial dissection in the dartos, you ligate the superficial veins and arteries. After that has been achieved, you remove this tissue while preserving an additional length of the urethra. You pass sutures through the corpora cavernosa to ensure hemostasis. And then after this layer has been sutured, you create a spatulated new meatus and then close the skin over it. So this is the basic steps of a partial penectomy. This is how it looks at the end of the procedure. There's a proper covering of the glands with the prepucial skin, and this is the new meatus that has been formed. It is wide enough to allow for good voiding. Okay, total penectomy is a bit of a misnomer because the penis is amputated at or near the level of the suspensory ligaments of the penis, and the more proximal parts of the corpora cavernosa are not usually removed. So, a total penectomy is not exactly a radical penectomy. Some part of the proximal corpora cavernosa may be left behind. It is indicated for penile tumors whose size or location would not allow excision with an adequate surgical margin with preservation of a sufficient stump that would allow upright voiding. Okay, so a bigger tumor, you have to isolate the urethra in a way that you can create a perineal urethrostomy. So transection of the corpora near the level of the pubis, that's the step. And then mobilization of the remaining urethra off from the proximal corporal bodies. This is the mobilization. And then transposition of the urethra through a curvilinear perineal incision, a small curvilinear incision in the perineum behind the scrotum, bring the urethra out and create a perineal urethrostomy. Okay, this is how it looks. So the bulbar urethra is mobilized dorsally away from the corporeal bodies, and then it is brought out from the perineum. So this is a flap perineal urethrostomy with the more dissection of tissues around it, and then we close it. So this is how it looks at the end of the procedure, a wide spatulated perineal urethrostomy. Okay, sentinel lymph node biopsy, another thing that I'll just touch upon. This was described by Cabanas. The concept is penile lymphangiographic studies are consistent with the drainage of the penile lymphatics into a sentinel node or group of nodes, which is located at the superomedial part of the SF junction in the area of the superficial epigastric vein, as we saw in the diagram earlier. So the idea is, if you can biopsy a sentinel lymph node, and if it is negative, most likely the other lymph nodes are not going to be involved, because just like the breast cancer, in penile cancer as well, the lymphatics follow a predictable path usually, and the sentinel lymph node is supposed to be involved first. If it is not involved, it is very less likely that the tumor may have metastasized to other groups of lymph nodes. Dynamic sentinel node biopsy, or DSNB. So the precise location of a sentinel lymph node with the lowest morbidity of any surgical staging technique. The goal is to define where the sentinel lymph node is located by using a combination of a visual dye and a radioactive dye. So a visual dye is usually a vital blue dye, and a radioactive dye is usually injected, and it is detected with the help of a handheld gamma probe. So The technetium 99M labeled nanocolloid sulfur is the radioactive dye, which is injected around the lesion the night before surgery. And an isosulfan blue or methylene blue is given intradermally around and into the lesion half an hour before surgery. So you are combining a visual dye with a radioactive dye, and this gives you the highest rate of detection of the sentinel lymph node. So the gamma camera will give you images like this, where the sentinel lymph node may be located. This is the dynamic image. All right, we don't need to go into details of this. There are some ultrasound criteria for lymph nodes. Okay, treatment-wise, in inguinal anatomy, we've talked about the superficial group, the deep group, and the node of the clocket as well. The Dressler's region, so this is basically the region, the four regions, the central group and the superomedial, superolateral, inferolateral, inferomedial. And this is how the lymph nodes are arranged around the saphenofemoral junction. Okay, this diagram we've already seen. Okay, risk-based management of the inguinal region. We don't need to go into too much detail of this topic. So for low-risk patients, carcinoma in situ, varicose carcinoma, and stage T1A, grade 1 and 2. There's a low incidence of positive lymph nodes, so a watchful waiting can be done. For high-risk patients, anybody with 1B or greater is considered high risk for inguinal lymph nodes. There's a 50% incidence. So a staging procedure is warranted even if the patient is having a clinically negative groin. Okay, this is an important slide. I'll spend a couple of minutes on this. So here you have the lowest grade, that is TIS and TA. If the physical examination of the groin is negative, you can just observe. If it is positive, you can give a course of antibiotics because it may be secondary to infection of the lesion. If the adenopathy persists even after this, then you do an FNAC. If it is negative, you can do an excisional biopsy. If it is positive, you can proceed to a formal lymph node dissection. If the excisional biopsy is negative, you can observe, and if it is positive, you can proceed to the same formal dissection. In T1, grade 1 and 2 with no vascular invasion and a superficial growth pattern, if it is negative, again, you can observe. If it is positive, you do an FNAC right away. So the difference is here you give a 4-week course of antibiotics and then reassess. Move to the ipsilateral inguinal, superficial and deep, and pelvic lymph node dissection, and the contralateral superficial inguinal dissection. Why we do a contralateral inguinal dissection? Because there's a crossover of penile lymphatics in the presymphyseal region. If the FNAC is negative in these cases, then we can give a course of antibiotics and wait. And again, it may resolve. If it does not, we do an excision biopsy and then we wait for negative or positive. If it's positive, we proceed with the positive algorithm. If it's negative, we can observe. In T2 to T4, in all the cases, whether it's negative or positive, we have to do some kind of inguinal lymph node dissection. So if it's bilateral negative, we do a bilateral superficial. We send it for frozen section. If it's positive, we proceed to a full superficial deep and pelvic lymph node dissection. If it's negative, we observe. For a unilateral positive mobile, that is less than 4 centimeter unilateral positive node, we do an inguinal superficial plus deep and pelvic lymph node on the same side, excuse me, and a contralateral superficial for the other side. Okay, if any of these is positive, you complete the pelvic lymph node dissection. If it is negative, you observe. And if it is bilateral positive, less than 4 centimeters, we consider an FNAC. And if it is negative, we follow the negative algorithm. If it's positive, we go for a bilateral ilioinguinal dissection and then for adjuvant therapy. If it is, or we can choose a neoadjuvant chemotherapy followed by ilioinguinal dissection. So the details of these things may not be much important at the undergraduate level, but you should have a basic idea that the inguinal lymph nodes are managed based on a risk assessment of what stage the primary tumor is. If there's a fixed nodal metastasis, if the lymph nodes are more than 4 centimeters, or if there's pelvic lymph nodes on imaging, we first give an induction chemotherapy. So this is advanced disease. You don't proceed with lymph node dissection straight away. You first give induction chemotherapy. If it is responsive, you do aggressive surgical resection. If it is progressive, they may need palliative chemotherapy, or if there's further progression, they may need a hospice referral. So this is very poor prognosis. All right, incisions and surgical techniques are not relevant at that level. All right. So this is the two templates, the classic standard groin dissection and the modified dissection. Right. I would not go into the detail of the surgical steps. I'll just move ahead with this. Okay, the pelvic lymphadenectomy should include the distal common iliac, external iliac, and the obturator nodes. And there's no further benefit gained by going further proximal in the iliac or para-aortic dissection. Complications of inguinal lymph node dissection. Number one is seroma. Number two is lymphocele. And another one, most common, is flap necrosis. So the skin undergoes flap necrosis. Again, this is very similar in breast cancer as well. So if we want to prevent a flap necrosis, we have to maintain good degree of sterility, and the flap that is raised should be vascular enough, thick enough to prevent necrosis. In spite of everything, there's a incidence of 5 to 20% of complications in inguinal lymph node dissection. Okay, modified inguinal lymph node lymphadenectomy, so a shorter incision and limitation of the dissection by excluding the area lateral to the femoral artery. So if you go back to this diagram, if the femoral artery is located somewhere here, lateral to the vein, so we don't go beyond this. We don't go lateral to the femoral artery. That is the idea of a modified inguinal lymph node dissection. And preservation of the saphenous vein, and elimination for the need to transpose the sartorius muscle. So these are some modifications that have been done to decrease the morbidity of the procedure. All right. Right. So to prevent or to bring down the complications of inguinal lymph node dissection, a laparoscopic approach known as VALE or video endoscopic inguinal lymph node dissection or inguinal lymphadenectomy has been devised, and it is becoming more and more common now. This is the placement of the 4 ports, 2 5-millimeter ports laterally and a couple of 10 or 12 millimeters more medially. And we keep the landmark of the medial border of the sartorius and the lateral border of the adductor longus. This is our area of interest, and this is the inguinal ligament. So this is how it is done. Follow-up after the surgery with no evidence of inguinal adenopathy. 1 to 2 years in the low-risk group, every 3 months. In the high-risk group, every 2 months. In the 3rd year, every 4 months for the low-risk group and every 3 months for the high-risk group. In the 4th year, every 6 months in both the groups, and then annually thereafter. Okay, adjuvant chemotherapy. So patients with high-risk features, as you saw earlier in the flow chart, they are candidates for adjuvant chemotherapy. Pelvic lymph node mets, extranodal extension, this is very important. Bilateral involvement and more than 4 centimeter size of the primary tumor. 4 cycles of TIP, that is paclitaxel, ifosfamide, and cisplatin. An alternative is 5-fluorouracil and cisplatin. Neoadjuvant chemotherapy, as you saw, bilateral or fixed nodes, more than 4 centimeter inguinal lymph nodes, or unresectable T4 primary tumors. They are candidates for neoadjuvant chemotherapy that is given before surgery. Again, 4 cycles of TIP, and response rate is about 50%. Long-term progression-free survival is about 36.7%. All right. In metastatic or recurrent disease, a monotherapy in the form of cisplatin or bleomycin or methotrexate is tried. Even some combination therapies have been tried. Radiotherapy. So radiotherapy is given in the curative, adjuvant, as well as palliative settings. External beam radiotherapy, the primary advantage of radiation therapy is organ preservation. And brachytherapy or external beam radiotherapy, both can be given in early stage lesions, especially T1 and T2, for penile preservation. A patient ineligible for brachytherapy based on the tumor size, like more than 4 centimeters or depth more than 1 centimeter or stage T2 and more, can be considered for external beam. Brachytherapy, so the ideal tumor for a brachytherapy should be less than 4 centimeters and less than 1 centimeter of invasion. It can be an interstitial brachytherapy or a mold-based brachytherapy, a mold plesiotherapy as it's called, an iridium implant or an interstitial implant. An iridium mold or an interstitial implant with wires may be used for brachytherapy. Indications, so lesions again less than 4 centimeters with invasion of corpora less than 1 centimeter, typically for the T1 and T2 tumors, and volume size less than 8 cc in use of less than 6 needles. These are technical details. A mold is usually built in the form of a box or a cylinder with a central opening and channels for placement of radioactive sources. So the cylinder and sources should be long enough to prevent underdosage at the tip of the penis. A dose of 60 to 65 gray at the surface and approximately 50 gray at the center of the organ is delivered over 6 to 7 days. Alternative, a single or double plane implant can be used to deliver this dose in 5 to 7 days. Interstitial brachytherapy, so you need to put implants, that is in iridium wires. This is usually done under general or spinal anesthetic. A catheterization is done to assist in urethra identification and to avoid injury by these needles into the urethra. And rigid steel needles may be used. They are held in pre-drilled parallel acryli templates or parallel flexible nylon catheters, which are placed 1 to 1.5 centimeter apart. Complications, telangiectasias, very, very common. Meatal stenosis may be seen in 30%. There may be some dermatitis, dysuria, some strictures, and penile fibrosis or penile necrosis may be seen in about 3 to 15%. This is higher with the interstitial group, and very rarely there may be small bowel obstruction. All right. Some less known, so most common malignancy of the penis is the squamous cell carcinoma, and the less common ones are basal cell carcinoma. The treatment is wide excision with a 2 centimeter clearance, and there's no need for lymph node dissection. This tumor does not commonly spread through lymph node route. Melanoma treatment is excision, and a lymph node dissection is a must in this because it's very, very highly metastatic through the lymph route. Sarcomas, again, excision is the treatment and lymph node only if it is positive. Paget's disease, a wide excision is enough, and there's no need for a lymph node dissection. Secondaries from any other primary in the body. So excision is the treatment, but it has a very poor prognosis. All right, this covers most of the common topics under the heading of the penis. I'll just have a quick look at the time. It's already 11:50, so we'll try to cover topics of the urethra quickly. Okay, surgical anatomy of the urethra. This is another important area for undergraduates. The male urethra is about 20 centimeters long. It is divided into 3 parts, the prostatic, the membranous, and the spongy. There may be a pre-prostatic part described in some books. It is, okay, so the anterior urethra is about 16 centimeters long, surrounded by the corpus spongiosum, divided into the bulbar and the penile parts. So the bulbar and the penile urethra together are known as the anterior urethra. Bulbar is the proximal one, surrounded by the bulbospongiosus muscle. It lies entirely within the perineum. And the penile urethra, which is distal, and it continues up to the tip of the penis. The posterior urethra is about 4 centimeters long, 4 to 5 centimeters. It lies in the pelvis. It is proximal to the corpus spongiosum, and it is divided into a pre-prostatic part, as I said, a short part, and then a prostatic part, which is the widest part of the male urethra, and then a membranous part, which is between the sphincter. It is the shortest and narrowest part of the male urethra. It is in the deep perineal pouch. It is surrounded by the external urethral sphincter. So this is the diagram. The bladder, a short pre-prostatic part of the urethra, then the prostatic part surrounded by the prostate. After that, the membranous urethra, surrounded by the external urethral sphincter, shown in orange here. And this is the deep perineal pouch. The bulbourethral gland is located here in the deep perineal pouch. After this, there is the bulbar part. So the bulbourethral duct opens in the bulbar part. And there's a bend here. This is the first bend of the urethra, which is in the bulbar urethra. And this continues into the penile urethra. There's a second bend here when the penis is flaccid. So this is basically the idea. There's a distal expansion of the urethra just before the meatus in the submeatal region. This is known as the navicular fossa. Okay, pre-prostatic urethra, only about 1 centimeter in length. It extends from the base of the bladder or the bladder neck up to the prostate. Some small periurethral glands may be located at this site, and they may contribute to BPH and symptoms of obstruction. Okay. So the prostatic urethra is very important because a lot of openings are there in this part of the urethra. It's about 3 to 4 centimeters in length. And in the middle, you can see the prostatic utricle, which is an embryological remnant, and two openings, the openings of the ejaculatory ducts. So this is where the semen would come out into the urethra. And there are multiple small openings located laterally. These are ducts from the prostate, from the glandular elements of the prostate. Okay. Features it in its posterior wall. There is a urethral crest. So this structure is known as a urethral crest, the swelling like thing on the posterior wall of the prostatic urethra. And it's this particular part is known as the verumontanum. It's a very important landmark in prostate surgery. uh, there's a rounded swelling called the colliculus seminalis in the middle. There are three openings on the colliculus seminalis, one median, that is a prostatic utricle, two lateral openings for the ejaculatory ducts. On either side of the urethral crest, there's a shallow depression, prostatic sinus for prostatic gland ducts opening, as we saw earlier. Okay, membranous urethra lies in the deep pouch, as we saw in the diagram. This is the narrowest segment of the male urethra, and there are thickened circular muscles in its walls which form the external sphincter. It is most susceptible to injury during the passage of an instrument or a catheter because it has delicate walls. It is the narrowest, and there's an angulation there. All right. Spongy or penile urethra, longest part of the male urethra, about 15 centimeters in length. It begins below the perineal membrane and ends at the external urethral meatus. It lies within the bulb of the penis, corpus spongiosum, and up to the glans of penis. There are two dilatations in the penile urethra, one intrabulbar fossa and one in the navicular fossa. The ducts of the bulbourethral or Cowper's glands open in this part just below the urogenital diaphragm, as we saw. The dorsal wall of spongy urethra has openings of many mucous glands, lacunae or pit-like recesses directed towards forwards. The lacuna magna lies in the navicular fossa. The spongy urethra extends at the external urethral meatus, that is a sagittal slit. It's a midline sagittal slit, about 6 millimeter long at the tip of the glans. The external meatus is guarded by two lateral labia. It is the narrowest point of the male urethra. If an instrument can pass through it, it can easily pass through the rest of the urethra. Arterial supply, so there's a urethral artery just below the perineal membrane, arises from the internal pudendal or the common penile, runs through the spongiosum to reach the glans, supplies the urethra and the erectile tissue. In addition, it may be supplied by a branch from the dorsal penile artery via the circumflex branch, and retrogradely from the glans by terminal branches. So blood supply, antegrade as well as retrograde. Venous drainage, anterior urethra drains into the dorsal vein of the penis and internal pudendal veins which drains into the prostatic plexus. And posterior urethra drains into the prostatic venous plexus directly and also into the vesical venous plexus. This finally drains into the internal iliac veins. Lymphatic drainage. Okay. Lymphatic drainage, vessels from the posterior urethra pass mainly to the internal iliac nodes. A few may go to the external iliac nodes. Vessels from anterior urethra accompany those of the glans, end in the deep inguinal lymph nodes, and some end in the superficial inguinal lymph nodes. Vessels from the membranous urethra go directly to the internal pudendal artery and drain following the lymphatics of that artery. Okay, a short look at the female urethra, only about 4 centimeters long and 6 millimeters in diameter, extends from the neck of the bladder to the external urethral meatus. The external orifice is situated in front of the vaginal opening and about 2.5 centimeters behind the glans clitoridis or the clitoris. It is homologous with the upper part of the prostatic urethra of the males, and the location, the female urethra, is embedded in the anterior wall of the vagina. Thus, in cases of difficult childbirth, it is more likely to be lacerated. The lumen of the urethra on cross section at the internal orifice is crescentic. At the middle is like a transverse slit, and at the external orifice is a sagittal slit. This is for the male urethra. Okay, glands around the female urethra. This may be seen in the female urethra as well. All right. Glands around the female urethra, urethral glands, tubular mucous glands. Paraurethral glands correspond with the prostate gland of the male. Greater vestibular glands, these are compound racemose glands situated behind the bulb of the vestibule in the superficial perineal pouch. And the ducts of the glands open in the vagina below the hymen. They correspond to the bulbourethral glands of the males. The greater vestibular glands are the homologue of the bulbourethral glands of the male. MCQ point. Urethral lacunae, these are pit-like mucous recesses which project from entire female urethra. An applied anatomy point. So infection of the female urinary bladder is more common due to the shorter size, shorter length of the urethra. Retrograde transmission of infection is more common in women. Stress incontinence is associated with the funneling of the bladder neck during normal standing, usually observed in multiparous women with symptoms of sudden dribbling of urine during increased intra-abdominal pressure. So on coughing, sneezing, or even on lifting something heavy, there may be leakage of urine. Okay, urethral stricture is something that is very common in our country, and this is the most common disease affecting the urethra. It's an abnormal narrowing or loss of distensibility of any part of the urethra due to fibrosis in and around the urethra, which can lead to partial or total obstruction to the flow of urine. It could result from injury, infection, or inflammation. So 3 I's can cause urethral strictures: injury, infection, or inflammation. It occurs when the urethra heals by fibrosis because of proliferation of fibroblasts. They're seen more often in males, obviously, because it has a longer, men have longer urethra and it is prone to more urethral strictures, and they're more susceptible to injury in men. It can be seen in any part of the urethra, and there are various kinds of classifications. So congenital pinhole meatus, traumatic stricture because of external trauma or internal trauma due to an instrumentation or due to a foreign body in the urethra or the passage of a urethral calculus or even douching in women. Post-operatively, there can be transurethral surgical procedures which can lead to formation of strictures and also vaginal repair. Inflammatory, so acute or chronic gonorrhea, non-specific urethritis, tuberculous urethritis, and schistosomiasis are causes of inflammatory strictures. So stricture due to fibrosis of the urethra or its surrounding structures. When the urethra gets injured due to any of the factors listed, the fibroblasts proliferate, laying down scar tissue and eventually contracting to form scars. These scars are what are known as strictures and may partially or totally obstruct the urethra. Most strictures occur in the bulbous urethra, followed by a pendulous urethra and the glandular urethra. So bulbar strictures are most common, about 60 to 70%. They can also result in dilatation of the urethra proximal to the stricture because of obstruction. There can be compensatory hypertrophy of the bladder musculature. There can be a vesicoureteral reflux, a VUR, resulting in hydroureters and hydronephrosis. So the upper tract undergoes changes because of high pressure in the bladder outflow tract. And urinary retention also increases the risk of infections such as periurethral abscess, rupture of which can lead to urinary fistulas. It can also cause infection in the adjacent organs like prostate, prostatitis, bladder cystitis, or into the kidneys in the form of a pyelonephritis. Clinical features: dysuria, spraying of the urinary stream, increased frequency, abdominal pain, urethral discharge, hesitancy, which is difficulty in initiation of the urinary stream, dribbling of urine, acute or chronic retention, extravasation of urine, and uremia. These are common clinical features associated with urethral strictures. On examination, sometimes there may be induration, the palpation of an abscess, there may be the presence of a fistula, or there may be chronic retention with a visible bladder. Okay, investigations: the peak flow rate done on a uroflowmetry, a post-void residual urine, which can be measured with ultrasound, urine analysis, renal function test, imaging, instrumental examination or urethroscopy, which is basically a cystoscopy and urethral assessment, where we exactly look at the lumen of the urethra and find the location of the stricture and the adequacy of the lumen of the stricture. Okay, this is the imaging test, urethrogram, retrograde urethrogram, where contrast is injected from the meatus, and when there's a stricture, you get a picture like this. This is the tip of the penis, this is the normal urethra, and this is a stricture in the bulbar part of the urethra. This is another image showing stricture in the urethra. This is the location of a bulbar stricture. We will not go into much detail at the undergraduate level. This is a picture showing a penile urethral stricture on a urethrogram. So differential diagnosis for a patient presenting with features of bladder outlet obstruction can be a BPH, a prostatic carcinoma, or a bladder carcinoma. Complications arising because of strictures can be UTIs, urethral or vesical calculi, secondary to obstruction, a urinary retention, which can be acute or chronic, extravasation of urine, urinary fistulae, infertility, and even carcinoma. So the urethral strictures can be managed in two ways: temporary and specific measures. Temporary measures are to get rid of the obstruction in the acute presentation. So urinary retention can be managed with a suprapubic cystostomy, commonly known as SPC, and insertion of a catheter. Extravasation of urine can also be managed in the same way. Watering can scrotum, where there are multiple fistulae in the perineum, are also managed by diversion of urine in the form of a cystostomy. And if a patient develops uremia secondary to obstruction, again, SPC is the initial treatment for that patient, along with supportive measures. Specific measures. So dilatation in the past used to be a common procedure. It is less commonly done now. It's a palliative method in which a bougie is passed at intervals of 2 weeks or 1 month, and then at 3 and 6 months. It is indicated for possible incomplete strictures. There can be complications like bleeding, clot retention, urethral rupture, infections, endotoxic shock, and even rupture of the prostate in patients with prostatic enlargement. So dilatation is not a very safe technique for management of urethral strictures. Endoscopic direct visual internal urethrotomy, a VIU or a OIU. It involves the incision of the stricture under direct vision using a urethrotomy. This is done with the help of a cystoscope. It is indicated for uncomplicated, impassable strictures, and it is not used in cases that are complicated by fistulae or external fibrosis or calculi. It is advisable to splint the urethra passing a catheter, kept usually for 3 to 4 days. And complications again can be bleeding, clot retention, extravasation of the irrigation fluid, and infection. Urethroplasty. So urethroplasty is actually the gold standard treatment for urethral strictures. It's an open plastic repair of the urethra using various approaches. It is indicated for patients with failed conservative measures or with urethral strictures which are having extensive spongiofibrosis or coexistent periurethral abscesses, or for very long panurethral strictures. It is done depending on the location of the stricture at the meatus, a meatotomy or a meatoplasty. For the anterior urethra, sometimes an excision, an end-to-end anastomosis may be performed, or a two-stage urethroplasty, or a skin island flap, or a free graft urethroplasty. A free graft urethroplasty usually involves the placement of a graft like a buccal mucosal graft onto the urethra and a plastic repair of that. Posterior urethra, mostly an anastomotic urethroplasty is performed, and sometimes penile or scrotal flap or inverted U-shaped scrotal flap operation may be performed. So to conclude, urethral strictures develop as a result of injury to the urethra, leading to fibrosis and obstruction to the flow of urine through the urethra. It is commoner in males. Urethral stricture can result in retention, infection, abscess, and extravasation of urine. Other conditions that can affect the urethra are inflammation in the form of urethritis. Urethritis can be due to gonococcal urethritis or non-gonococcal urethritis. The non-gonococcal causes include E. coli, chlamydia, mycoplasma. It is often accompanied by cystitis in women and prostatitis in men. Symptoms can be local pain, fever, itching, and frequency. Rieter's syndrome, a classical triad of arthritis, conjunctivitis, and urethritis, an MCQ point. Okay, some tumor and tumor-like conditions. These are very rare in the urethra. Urethral caruncle presents as a small red painful mass, and it may be covered with intact mucosa. It is extremely friable, bleeds to slightest trauma. On histologic examination, there may be inflamed granulation tissue or a polyp may be seen. Benign epithelial tumors include squamous and urothelial papillomas, inverted urothelial papillomas, and condylomas. A urethral polyp may include an inflammatory polyp, a caruncle, a urothelial papilloma, nephrogenic adenoma, and polyp, and they may present with dysuria and hematuria. So the names are enough at the undergraduate level, and these are quite rare. These are not really common. On histology, you can see polyps that are lined by prostatic type epithelium. They may be solitary or multiple. They may be characterized by a papillary or filiform fibrovascular core, and the luminal layer is columnar, whereas the basal layer is cuboidal. They may contain some acini, and there may be some corpora amylaceae. This is from the prostatic tissue. Majority of them strain for PSA and PSAP, the prostatic specific antigen, using immunohistochemistry techniques. Okay, congenital posterior urethral polyps or fibroepithelial polyps, these are also quite rare. These are seen in young boys who present with mild symptoms of bladder outlet obstruction and hematuria. They may be located in the area of the verumontanum. Histologically, there may be congested or edematous fibrovascular stroma lined by transitional epithelium. Carcinoma of the urethra is very rare. Male urethral cancer. In prostatic and membranous urethra, tumors arising are usually transitional type, and they're usually associated with bladder tumors. We do see a few cases of these in advanced bladder tumors. They do not express PSA or PSAP antigens, so they are not exactly arising from the tissue of the prostate. They are not hormone sensitive. Bulbous and membranous urethra tumors are mostly squamous type and rarely associated with a vesical neoplasm. Female urethral cancer is usually epidermoid cancer. In proximal 2/3, the tumors are transitional cell type and often associated with bladder tumors. In distal 1/3, they're usually squamous cell type. Adenocarcinoma of the urethra, very rare tumors, arise from the periurethral glands or through the metaplasia of surface urothelium. Another common benign condition involving the penis before we close the class today, phimosis and paraphimosis. So abnormally narrow prepuce, which cannot be normally retracted, is considered as a phimosis. It can be primary or secondary, so a congenital or an acquired. It can result in urinary obstruction. It can increase the risk of recurrent infections. It can also increase the risk of penile cancer. Paraphimosis occurs when there's a forcible retraction of the prepuce in cases of phimosis. It is an extremely painful condition, and it can cause severe congestion of the glands and also result in acute urinary obstruction. This condition is a surgical emergency, and usually it is managed by either manual replacement of the foreskin back to its normal position. If that is not possible, a dorsal slit may be performed to release the tight band proximal to the corona. Okay, this is a picture of the phimosis, and this is when paraphimosis occurs, leading to a congested glans, and there's severe edema of the prepucial skin. Okay, hypospadias and epispadias. So an abnormal ventral opening of the external urethral meatus is known as a hypospadias. This is more common, and a dorsal opening of abnormal dorsal opening of the external urethral meatus is known as a epispadias. There's increased risk of infection, and the ejaculation is not proper. So for young men, it may cause infertility because of improper deposition of the semen in the female tract. We'll not go into the details of hypospadias and epispadias. Inflammation involving the penis. So balanitis and balanoposthitis, both are very common conditions. Inflammation of the glans is known as balanitis, and involving the glans and prepuce is known as balanoposthitis. Both can be caused by bacteria as well as fungi. So those caused by pyogenic bacteria like gonococcus or anaerobic bacteria, and in fungi, the most common is candida. This is more commonly seen in diabetics. Mycoplasma, chlamydia, and Gardnerella are other causes of balanoposthitis. Usually, it is a consequence of poor local hygiene in uncircumcised men, and diabetes may be an underlying finding in a lot of cases of balanoposthitis. All right, thank you very much. Any questions from our students? Okay, so we don't have any questions from the students. Are we good to close the session? Am I audible? Hello?
Yes, sir. There is no question. There are no questions from these students.
How many students joined?
Sir, just a second. So there are 25 registrations so far.
Okay. All right. So I'll be closing the session now. Thank you very much.